Okay, let's pick up on the bone conversation. So this image on the screen is looking at the microarchitecture of normal bone versus osteoporotic bone. When you mechanically unload bone, you lose bone mass. Basically, when you don't mechanically load bone, you reduce the amount of new bone being laid down. And a lot of data has been collected on long duration space flights where astronauts are losing a significant amount of calcium per day, which can result in 2 to 3% loss of trabecular bone mineral density per month. And those studies were done in the hip, as you can see in your notes. When you take away the mechanical loading of bone, you break bone down. So let's look at our final case. 74-year-old woman complains of complains of loss of balance for the past 2 years, difficulty maintaining the same posture for more than 15 to 20 minutes, and general body fatigue. Her medical history is osteoporosis, hypertension. She's on meds for osteoporosis but does not currently exercise. The first question you have to ask, with this diagnosis of osteoporosis and the complaints that she is having, is physical therapy appropriate? So you do an examination. Her posture is short and thin with an exaggerated thoracic kyphosis, rounded shoulders, and increased lumbar lordosis. She has full spinal range of motion but pain at end range extension. And her manual muscle testing shows weak buttock musculature and core muscles. Can exercise help? Well, it kind of depends on what that question is asking. Let's specifically first just talk about bone. Can exercise help bone? Hopefully you guys remember and are familiar with Wolff's Law that osteoblastic activity is proportional to the forces exerted on the bone. So whether it is a tendon pulling at its insertion site, the compression forces from gravity, or the loads placed upon bone with physical activity, when something pulls, pushes, compresses a bone, it stimulates osteoblastic activity. The images on the screen all show different types of physical activity that include those forces listed. The effect of Wolff's Law is dependent on the intensity of the force. As you increase the load, you get a greater effect in the bone. So swimming is, in fact, good for your bone mineral density. It has muscles that are connected to tendons that are pulling on bones during that activity. But your body weight is supported and there's no impact. So if you go one slide picture to the left and you see runners, this would have a greater impact on bone. And then if you create high jumping, intense power loads, you get an even greater effect on bone. So all physical activity is good for bones. If you are targeting an activity to increase bone mineral density, the greater the load on the bone, the greater the effect. So that's answering the question kind of the type of load. Let's just quickly remind ourselves about when in life is this the most important. If you could pick and you could just, grab your patient at any point along their entire lifespan when you could make a difference in their bone mineral density, the absolute best time you could do it is during this prepubescent time where there is rapid bone growth. This is when your body is laying down more bone. Once you get to your early 20s, you have reached your peak bone mass. That is the highest amount of bone mineral density you will ever have, and from then on out, you will slowly lose it. The rate that you lose it will be dependent on your sex and your hormones and your physical activity and your diet. So once you get 30s and beyond, you are beginning the process of bone loss. Obviously, the line for men and women is very different because women have the cliff that they fall off of when they go through menopause and they lose the influence of estrogen. So as you listen to this video, most of you are just reaching your peak. Anything you can do right now to target your bone mineral density will pay off huge 40, 50 years from now, depending to determine kind of how low you fall. Because your peak bone mass is your bone bank. It's what you have in the bank that you can then spend for the rest of your life. And the higher that bank gets, the higher your peak bone mass, the less likely you will reach fragility in later in life. So the question was, can exercise help? And I first directed us just at, does exercise do anything to bone? Absolutely yes. Bone is very, very reactive to physical activity and responds to Wolff's Law. I would argue that this patient coming in would benefit from an exercise prescription for maybe 4 separate reasons. And you can decide kind of which of these goals is appropriate for your patient and why they're coming in. An exercise prescription could be administered to build bone mass. An exercise prescription can be used to slow the decline of bone mineral density. An exercise prescription may be used to prevent fractures and possibly just used to maintain muscle mass and strength. So let's go through each one of these individual goals. The first one being, I have a goal of building bone mass, actually increasing bone mineral density with exercise. Is this possible? Yes. The type of exercise prescription that can do this is very difficult to administer with compliance and be successful, but research has shown that it is possible. You can increase bone mineral density in a specific area if you really target physical activity on the muscles that directly attach to that bone. So if somebody has found that they have a significant loss of bone mineral density in their femoral neck, they could target muscles that specifically attach to the femoral head and neck. And if they strengthen and they work those muscles and pull directly on that bone, the evidence shows they can increase bone mineral density. The negatives, that's great. That's great that we can do that. That's wonderful. The negative is that the studies that have shown an increase in bone mineral density are incredibly long duration. Most of them require at least 11 months of regular, pretty intense, as you'll see just below, physical activity to get the effects. There's some studies that have shown it at 9 months, but in general, if you do the sum total, probably more than 11 months is required. At a pretty high intensity, 70 to 90% of your 1 rep max on the muscles that are attaching to the specific bone. 2 to 3 sets of 8 to 12 reps. That's pretty intense. And then you need to do it 3 to 5 days a week. So can it be done? Absolutely. And there'll be times or people in your life and your careers where this might be a really important goal. But most often, we prescribe an exercise prescription with the goal of slowing the decline in bone mineral density. And most studies that are done on exercise and bone show that exercise, like 2 groups of people, control and an exercise group, the exercise group will have less bone loss over a set period of time than the control. They both are still losing bone mineral density, but the person who is inactive will lose it faster. That's probably in your lives and your patient population a more realistic goal of using exercise to slow down the rate of bone mineral density loss. So there's two different recommendations here from just different organizations. The Canadian Academy of Sports Exercise Medicine recommends 30 to 60 minutes of weight-bearing endurance exercise 3 to 5 days a week, coupled with strength training 3 days per week to effectively slow the decline in bone mineral density. The Belgian Bone Club has 15 to 60 minutes of weight-bearing and strength training for 2 to 3 times per week. So they're not significantly different, but you can see some differences in the recommendations. But in general, both include longer duration weight-bearing endurance exercise coupled with strength training. I put some additional information on this prescription in your notes. You'll see first there's some information on the type of endurance exercise. So the recommendations just say weight-bearing endurance exercise, but when you go into the studies that were done in this area, stair climbing and jogging show better effects on bone mineral density than walking, which part of that is intuitive, that obviously stair climbing and jogging have maybe higher loading forces. Stair climbing not as much as jogging. But one of the big things is walking is not a unique stimulus for your bones. And even if you compare that to stair climbing, that is just of a different tugging, a different pulling to actually cause an adaptation than this very constant stimulus that we have, which is walking. So walking programs that were implemented for up to a year show only modest effect at maintaining bone mineral density. So you have to read your patient, see what they're capable of, and know their risk profile with their bone health as it is. But walking in general is not the best option. You could even do something with less force if it was a unique movement pattern. Might be more important. When it comes to the strength training, whether it's 3 days per week or 2 to 3 days per week, the importance there is higher intensity of strength training. So you'll see that they recommend 70 to 80% of a 1 rep max. So even if that means you have to do fewer reps, the high load has a greater impact on Wolff's Law. So if, that kind of gets to that compliance issue, but when you look at the data side by side, moderate intensity resistance training does not generate the same increases in bone mineral density as when you ramp up the intensity. So if possible, higher load, lower reps, and as site specific as possible. Where they have deficits in bone mineral density should be where you're doing the strength training. So that's how you prescribe exercise if the goal is slowing the decline in bone mineral density. It might be that your goal really is preventing fracture. And I think you guys have a head around the whole fracture component from geriatrics. If they have osteoporosis, education on avoiding positions of spinal flexion and resisted rotation. That's where you can get into those compression fractures, which is a common site of a fracture and osteoporosis. Trying to work through alternate ways of performing ADLs that don't include a flexed posture and any kind of twisting in a flexed posture. Avoiding long lever arm exercises, especially if there's upper extremity bone mineral density changes. So that long lever arm is going to put a greater strain on the proximal bone. I do want to include, it's kind of in italics at the top of this in your notes, when you do strength training and when you do weight-bearing aerobic exercise, there is always going to be a risk of fracture. So you want to be as cautious and careful as you can in posture and positioning and letting patients know, especially if they are more frail, that that is a risk, but they have to move to make any gains. So we have to proceed with caution and know that we are dealing with some risks. If your goal is to prevent fracture, the best thing you can do is prevent them from falling. So any goals in your exercise prescription that involve improving strength, balance, and coordination will help to prevent falls. And if you prevent falls, you can prevent fracture. If you prescribe and teach them how to effectively use an assistive device, you can prevent falls, which means you can prevent fracture. You might go into their home and do a home assessment to look for things that might lead to fall to prevent fracture. Finally, you might have a goal of maintaining muscle mass and strength. We know from research that, especially when it looks at the back, the strength of spinal extensors correlates with bone mineral density. And weighted exercise has benefits for strength as well as bone. So you can kind of get the most out of both, maintaining strength around the bones, keeping people physically active, preventing falls, kind of all sort of gets wrapped up into one. So on the next page of your notes is the ACSM's fit recommendation for individuals with osteoporosis. Aerobic exercise is recommended 4 to 5 days a week. They give the intensity here. They make a note that this patient population might use the Borg 0 to 10 a little bit easier than the 6 to 20. So they give a separate rating there. Work up to the higher number of minutes per day, and weight bearing is preferred. They say walking or cycling, but if you can come up with a unique movement pattern beyond walking, that would be even better. Resistance training, you typically have to start with fewer non-consecutive days and then build up with the goal being 2 to 3. The intensity is going to have to be adjusted, but the goal is higher intensity training is better if tolerated. And then you kind of start with just one set of 8 to 12 reps and build from there. Equipment doesn't matter, just based on what they have and what they like. And then flexibility is encouraged. So for our patient who came in with osteoporosis, having poor posture, difficulty maintaining postures for more than 15 to 20 minutes, lots of loss of balance issues, the prescription included daily walking with a walking journal. So she started at 20 minutes and had a goal of working up to 45 minutes at an RPE of 3 to 4 on a 0 to 10 scale. She did strengthening 3 days a week, 2 sets of 10 to 12 reps. It included seated rows, lat pull downs, overhead press, and clamshell. She did balance exercises and daily stretching. After 4 weeks, she could walk for more than 30 minutes without taking a break. She could cook in her kitchen for more than half an hour. Strength and balance improved, and reports reduced fatigue. So even though she has underlying osteoporosis, and we are not going to realistically increase her bone mineral density back to normal, we can still make a huge impact, because a lot of the postural changes that come with osteoporosis, the forward head, the increased thoracic kyphosis, the loss of lumbar lordosis, the lax abdomen, that all contributes to musculoskeletal pain and abnormalities. And if you can work on the musculoskeletal system around the bone issue, you can make huge improvements in ADL performance, stamina, and being upright. If you can increase strength and balance, and you can eliminate some of those episodes of loss of balance, even if she has underlying osteoporosis, if you can prevent falls, you can prevent fracture. So there are a lot of musculoskeletal problems surrounding the bony architecture that has gotten weakened that can be addressed with physical activity. And we can certainly use exercise and prescribe it in a way where she gets these daily goals met, improve, reduce pain, increased ability to do ADLs, while also prescribing it in a way that helps to slow further bone loss. So really keeping in mind the many layers you can address with exercise, and prescribing exercise that has the most bang for their buck, where she gets the strength and the balance and the posture, and prescribed in a way that we help to delay the loss of bone mineral density. And that is the end. I hope you were able to take pieces and nuggets and patient population stories that you'll be able to apply, and that you feel motivated to use exercise to change people's life safely, monitoring when it's appropriate, using the appropriate fit recommendations so you're targeting the specific goals that you seek to reach. I'm really sorry that this had to all be in pre-recorded video mode. This is way more fun for all of us when we're together talking about it. But I hope that when the dust settles, you're walking away with some solid principles of exercise physiology that you can apply in your life as a PT. Take care, everybody.